Venous thromboembolism is a term that encompasses both pulmonary embolism and DVT. In PE, the embolus gets lodged into the pulmonary arteries. In DVT, a blood clot, also known as thrombus, gets lodged into blood vessels of the lower limb. The important thing to note is that around 50% of proximal DVTs will become PE, and a third of distal DVTs will become proximal DVT. The term provoked PE refers to when a major risk factor is present within 3 months. The term unprovoked PE refers to when a major risk is absent within 3 months. PE can be classified according to hemodynamic stability, which is helpful in deciding further management. The other classification is via using risk scoring systems. When the patient is hemodynamically unstable, that is hypotensive, this is termed as massive or high-risk PE and requires immediate thrombolytic therapy with TPA such as alteplase. When the patient is hemodynamically unstable, it is termed as submassive PE or intermediate risk PE. Wells score is therefore only used for hemodynamically stable PE. There is a 2-level Wells score and a 3-level score. A Wells score less than 4 means PE is unlikely and needs D-dimer test to confirm the absence of PE. A negative dimer in this case rules P out. If the Wells score is greater than 4, then patient requires admission and CTPA and anticoagulants. 3 different scoring systems are available. We have already discussed Wells scoring for hemodynamically stable patients. Hestia criteria is another scoring system that helps in deciding whether to discharge patient or not. Finally, there is PESI score, which stands for Pulmonary Embolism Severity Index. 1/3 of PE have no risk factors. The remaining episodes are caused by transient or persistent factors that increase the risk of VTE by inducing hypercoagulability, venous stasis, or vascular wall damage or dysfunction, known collectively as Virchow's triad. VT is a risk factor in 50% of PE. Recent history of surgery is present in 29% of patients with confirmed PE. The risk is higher for those undergoing major orthopedic surgery, e.g. joint replacement, significant immobility from bed rest longer than 5 days, or hospitalization or limb paralysis is present in 28% of patients with confirmed PE. Previous VTI. There is a lifelong risk of VTE recurrence after a first episode of PE. About 25% of people with PE have had a previous thromboembolic event. Active cancer. This is present in 22% of people with PE. Antiphospholipid antibody syndrome is reported in up to 14% of people with a VTE. Recent trauma or lower limb fracture. This is present in 11% of people with confirmed PE. Pregnancy and postnatal period, particularly 6 weeks postpartum. The risk of antenatal VTE is 4 to 5-fold higher in pregnant women than in non-pregnant women of the same age, although the absolute risk remains low, at around 1 in 1,000 pregnancies. Increasing age. The incidence and mortality from PE increase with age, and the age-specific mortality doubles for every 10 years starting at 25 years. Family history of VTE. There is a significantly increased rate of VT among first-degree siblings. This risk is increased more than 20-fold in people with 2 affected siblings. Minor risk factors include the following: obesity, body mass index greater than 30 kilograms per meter square, 1 or more significant medical comorbidities, long duration of air travel, cigarette smoking, indwelling central vein catheter, the use of combined oral contraception within the previous year or hormone replacement therapy. Combined oral contraceptives, containing both an estrogen and a progestogen, are associated with an approximately 2 to 6-fold increase in VTE risk over baseline, but in general, the absolute risk remains low. The increased risk associated with use of HRT varies widely and depends on the formulation. Complications of PE. Pulmonary embolism is a major cause of mortality, morbidity, and hospitalization. The mortality rate is lower in those who are hemodynamically stable and higher in those who present cardiorespiratory arrest. Severe cases of PE can lead to collapse and/or sudden death. Hemodynamically stable people with evidence of heart strain and/or myocardial infarction are at increased risk, with early mortality of 3–15%. About 5–10% of people present as hemodynamically unstable, and the risk of early death is greater than 15%. Chronic thromboembolic pulmonary hypertension, ECTEF, is a rare and potentially fatal complication of PE. A reported cumulative incidence of 0.1, 9.1% within the first 2 years after a symptomatic PE event. In people with CTEPH, fibrous tissue replaces residual emboli over months or years, leading to chronic obstruction of the pulmonary arterial vasculature, progressive increases in pulmonary arterial pressure, and, if untreated, right heart failure. Risk factors include large thrombus mass, thrombophilic disorders, history of splenectomy, history of cancer, myeloproliferative disorders, inflammatory bowel disease, and previous episodes of VTE. Following treatment, some people develop complications, such as chronic thromboembolic pulmonary hypertension, or experience persistent or deteriorating dyspnea, and poor physical performance for 6 months to 3 years after a PE. Independent predictors of reduced functional exercise capacity and quality of life over time included female sex, higher body mass index, history of lung disease, higher pulmonary artery systolic pressures on the 10-day echocardiogram, and higher main pulmonary artery diameter on the baseline computed tomography pulmonary angiogram CTPA. There is a greater risk of recurrence of PE in people with risk factors that are not transient or reversible, and after multiple episodes of venous thromboembolism, VTI. The risk for long-term recurrence can be classified as low, intermediate, or high, depending on the risk factor. Low, less than 3% per year. Surgery with general anesthesia for over 30 minutes, confined to bed in hospital for 3 days or more, trauma with fractures. Intermediate, 3% per year. Minor surgery, general anesthesia for less than 30 minutes. Admission to hospital for less than 3 days with an acute illness, estrogen therapy, or contraception. Pregnancy or puerperium, leg injury without fracture associated with reduced mobility for 3 days or more, long-haul flight. High, more than 8% per year. Active cancer, 1 or more previous episodes of VTI in the absence of a major transient reversible risk factor, antiphospholipid antibody syndrome. Recurrence rates may be up to 10% in the first year after withdrawal of anticoagulation treatment. One study of people with a first episode of PE found that the recurrence rate after discontinuation of treatment was 2.5% per year after PE associated with transient risk factors, compared with 4.5% per year after PE occurring in the absence of known cancer, known thrombophilia, or any transient risk factor. The frequency of recurrence does not appear to depend on the clinical presentation of the first event, that is, whether it was a DVT or PE. But recurrent VTE is likely to occur in the same clinical form as the first event. Signs and symptoms of pulmonary embolism are nonspecific. Symptoms typically have a sudden onset. The presence of risk factors such as pregnancy, previous DVT or PE, active cancer, or recent surgery makes the diagnosis of PE more likely. Symptoms. Dyspnea. This is the most common feature and is present in 50% of people with PE. It may be acute and severe in central PE, but mild and transient in a small peripheral PE. Hemoptysis. Pleuritic chest pain, present in 39% of people with PE pain, is normally localized to one side. Syncope or presyncope tachypnoea, present in 21–39% of people with PE, features of deep vein thrombosis, DVT, thrombosis. Retrosternal chest pain due to right ventricular ischemia. Cough, present in approximately 23% of people with PE. Signs: elevated jugular venous pressure, fever, gallop rhythm, a wide split-second heart sound, tricuspid regurgitant murmur, hypotension, systolic blood pressure less than 90 mmHg, and cardiogenic shock. Hemodynamic instability is rare. Scenario 1. If a patient is suspected to have PE, arrange immediate admission. This patient can be hemodynamically unstable or stable. Initial resuscitation includes oxygen 100%, IV access, and close monitoring. Give analgesia, example morphine, if necessary. Next, assess circulation and identify whether the patient is hemodynamically stable or unstable. An unstable PE is defined as someone with either cardiac arrest or hypotension with systolic blood pressure less than 90 mmHg. Thrombolytic therapy. The thrombolytic agent can either be given into a peripheral vein, systemic thrombolysis, or directly into the pulmonary arteries via a catheter, catheter-directed thrombolysis. Open pulmonary embolectomy, surgical removal of clots in the pulmonary arteries, is an alternative used less commonly in modern practice. In case of patients of PE who are hemodynamically stable need further classification by using the Wells score. A PE is likely when a Wells score is more than 4, and unlikely when a score is less than 4. For people with a Wells score of more than 4, a PE likely. Arrange hospital admission for an immediate computed tomography pulmonary angiogram, CTPA, and, where necessary, other investigations. If CTPA cannot be carried out immediately, offer interim therapeutic anticoagulation. If possible, choose an anticoagulant that can be continued if PE is confirmed, and arrange hospital admission. Then, if interim therapeutic anticoagulation is required, offer apixaban or rivaroxaban. Carry out baseline blood tests including full blood count, renal and hepatic function, prothrombin time, and activated partial thromboplastin time. Do not wait for the results of baseline blood tests before starting anticoagulation treatment. For people with a Wells score of 4 or less, PP unlikely. Offer a D-dimer test with the result available within 4 hours. If the test result cannot be obtained within 4 hours, offer interim therapeutic anticoagulation while awaiting the result. If possible, choose an anticoagulant that can be continued if PE is confirmed. If the D-dimer test is positive, arrange admission to hospital for an immediate CTPA and, where necessary, other investigations. If CTPA cannot be carried out immediately, offer interim therapeutic anticoagulation. If possible, choose an anticoagulant that can be continued if PE is confirmed. If the D-dimer test is negative, stop interim therapeutic anticoagulation, if appropriate. Advise the person that it is not likely that they have a PE, but discuss the signs and symptoms, and when they should seek further medical help. Consider an alternative diagnosis. Scenario 2 is a PE patient with high bleeding risk. For example, he's already on warfarin due to mechanical heart valves, or someone with peptic ulcer disease. In these cases, oral anticoagulants cannot be given, and therefore an IVC filter and/or embolectomy is the best management. Scenario 3 is PE in pregnancy. For example, a female in second trimester presenting with shortness of breath and chest pain. If there is concurrent leg swelling with sob in pregnant female, get Doppler ultrasound done and no need for CTPA or VQ scan, as we assume that the PE is from the DVT. Therefore, Doppler ultrasound is enough. If leg swelling is absent and Doppler is negative, and PE is suspected, D-dimer Wells score has no role, as it normally rises in pregnancy. We order ECG. It shows RV strain of PE. If chest X-ray is abnormal, send her for CTPA. If chest X-ray is normal, send her for VQ scan.